Good. So technical. It doesn't get any more real than this, guys. Okay. Something happened last time to David, right? We're cutting close, man. All right. Hi, everybody. This is Dr. Marco once again. And before I start, happy Easter weekend. Yeah. I know many of you are planning for probably a long weekend getaway because I am too, right? But thanks for those who still manage to vacate your evening time to spend with us and celebrate our episode 9 20-year anniversary of Bice Institute. I really, really appreciate it. Okay. We also have a very special guest today, but this guest you might not really know all that much, okay? Because he's kind of like the quiet one, the silent one, not so talkative one, but he's been with us for a long enough time, and although you might not know him well, those who know him really respect him, and he's been an integral part of our faculty for many years. So no further ado, I would like to welcome Dr. Michael Wong.
Hey
Yay.
Mark, how are you?
Hey, Michael. All right, I can see that you're obviously not in the Bice Institute mode because you're not wearing the proud red.
I'm
You're
so
wearing
sorry.
I'm just kidding. I'm just kidding.
That wasn't
Okay.
on my packing list.
There you go. I know. You can only pack so much. Okay, underwear, socks, okay, sunscreen lotion, okay, your toothbrush, Bice Institute. Oh, forget it.
Hey, Mark, I'm a type of person who perspires a lot, so I need two times twice the amount of underwears for this
There
day.
you go. There you go. Okay. I hope you pack enough underwear. Like seriously. So for those of us don't know, I mean, it was a surprise for me too. You're not in Vancouver, right?
No, I'm not.
You're
No.
somewhere hot and sweaty.
Well, yeah, it's hot and sweaty. Yes, yeah. We're in
You're in
Miami, Florida.
Miami. Miami, right?
The main purpose of my trip here today was to catch some tennis at the Miami Open here.
Oh, are
Yes.
you competing there?
Oh, yeah, right. No, I'm not that great. I'm not that good. Mark. No, I follow tennis a lot, very closely. So it's watching the men's and the women's tennis, the ATP and the WTA tennis here in
Oh,
Miami.
wow.
Yeah, yeah.
So what did you do?
Unfortunately,
Like
Jordan,
you
this
buy the
wasn't.
ticket and everything? You and your wife
Yeah,
went together?
that's right. Yeah, and spent
My
a few
goodness.
days there. We just took a break and we came back from the Florida Keys down south. Yeah, Key West. That was a nice drive. We spent a day there, so it's a really nice drive down to the Keys.
Wonderful. Who are you
Yeah.
rooting for in this tournament? Anybody that you are a big fan
Well,
of?
yeah, Alcaraz is my favorite player right now, but I just found out that he did lose tonight, so he's out of the tennis tournament. So,
Well, that makes it simple. Get the hell out of there and come back to Vancouver,
that's right.
okay?
Okay.
Oh no, that's wonderful that you're having a great time. What's
Yes.
what's the
Yeah.
weather like?
It's overcast with sunshine and windy, and yeah, it hasn't well it rained maybe one day, but overall it was pretty good. Nice and warm, sunny, overcast, so
Yeah,
it's really
sounds like
comfortable
a
weather.
Vancouver man.
Yeah, it's
Sounds
not
like
too humid
Vancouver.
right now. It's not too
Yeah,
humid right now. Yeah, yeah,
cool. Well, you know
yeah.
what? Thank you so much for joining us live from
Oh,
Miami. Okay, all
yes.
right. So, yeah, for the rest of us, right?
Mhm.
You're kind of like a lurker at the Vice Institute. You know what I'm saying? You like to be the silent type of the Avenger. You don't want to be flashy, right? You
No, I'm
kind
not. No.
of yeah, but you've always
Um,
contributed as a faculty, especially with the CIR, right? You
yeah,
always
yeah.
took care of your modules. Okay, yeah. Tell us about yourself a little bit.
Well, I was born and raised in Vancouver. Went to elementary, high school here in Vancouver. Then I went to the University of BC as
UBC.
under UBC. That's right. So I went
Where'd you study
undergrad.
undergrad?
Yeah, chemistry biochem, a double honors degree, which I
Mm,
didn't complete.
mm.
I did not complete that. So it was a double honors chem biochem. Got into dental school after my third year of my
Oh,
bachelor's here. Yeah, I always wanted to be a dentist since grade three. Grade three.
what
I'm not
happened in
sure if
grade
you're
three?
grade three will actually be some. I don't know if you guys had those, but we had the community sort of dentists come around into our elementary schools and taught us about the dental health. And since then, I just wanted to be a dentist, and I worked hard towards that. So it's just my goal. If I told my mom one time, Mom, if I don't get in dental school, I'm going to get my master's of business administration and maybe a law degree. So
And make
I
lots
know
of
with
money.
age, make some money exactly. So again, I always wanted to be a dentist, so I worked hard at it. So I got into dental school at UBC there
Oh,
as well.
wow.
Yeah,
For me, I
graduated
was totally opposite
1993.
to you. I was totally
Yeah.
opposite to you. I want to be a dentist because my dad's friend was a dentist and he
Oh,
was married to a very hot wife and he was
okay.
driving a hot car and he was playing golf twice a week. So I said, you know what? I'm
Nice.
going to be a dentist so I can get myself a hot wife, hot car, and play golf every weekend. Look at me. I don't play golf ever, right? Okay. I drive my little Volkswagen, right? And my wife is kind of hot. So that's the story.
I
Michael,
thought
when
you
did I
got a
meet
Miata.
you?
I thought you got
Sorry?
a Miata. I thought you got a
I have
Miata.
it. Oh yeah. I have it. But my Miata, um, I haven't drove like only twice. Yeah. So I'm waiting
Oh,
for the summer. I'm waiting for the summer.
okay, right.
I'm saving
It's
her.
a convertible. It's a
Yes,
convertible.
convertible. Yeah.
Right. Yeah.
Okay.
Yeah.
Yeah. I'll,
Yeah.
I'll, I'll let you sit beside me, and then yeah, we'll go for a
Okay.
ride.
Actually, my
Michael.
brother.
Yeah.
Actually, my brother, Mark, the Miata. My brother's bigger than I am, so he's driving the Miata, and he's looking over the
Oh yes. Yes.
windshield crossbar.
Yes.
So he's
Yes.
driving around like this.
Yes.
So I thought that was so funny. I always remember that.
Well, I bought my
So
Miata so that I can put a V8 engine. That was my whole
oh,
point. Yeah, and I'm
okay,
going to do it someday. Right?
okay.
I've got to upgrade my garage first. Right? Yeah, so that I'll have it done. It's one of my bucket lists. I'll make it happen.
Yeah,
I'll make it
yeah,
happen.
yeah. Get
Right?
that hoist. Get that hoist.
um, Michael, how long have we known each
Yes.
other?
I don't know, Mark. I think
That's
what
pathetic.
2009, 2010-ish. I'm
Somewhere
thinking
there.
around there. Yeah, yeah.
Yeah, we're not that. We
I
don't really have a meaningful relationship, do we?
yeah. You know what? It's quite. No, we don't. Short term here. But I did hear a lot about you. I heard about your name, early 2000s, the Mark Juan. And I've heard about your practice. It was a small little practice, very tight, crammed, in Metro Town. My classmate worked for you actually. Gloria Yan? Is it Gloria? You remember her? Years ago?
Not really.
No, okay. I visited that office because she brought me in there because I had to pick her up, and it was really small, Mark. I don't know how
Oh
you
yeah.
worked in there.
I know.
It's
Now like
very
it's just too
tight.
big. It's either too small or too
Yeah,
big.
exactly. That was so funny. Yeah, yeah. But
So-
how I met you was I started late in implant dentistry. I graduated in '93. I worked for 8 years as an associate, and it's in the early 2000s where I started getting into implantology, and I took a couple residence courses with Nobel. And after taking those courses, I just didn't feel confident. So I was looking around for more courses to take, and your name just kept on popping up.
Mm.
And I think the first course I took with you was with you and Bernard, Dr. Jin, at the soft tissue course. And I always remember I don't know, years back, yeah, the Perio Institute had that soft tissue course. Um, yeah, yours and Dr. Jin's soft tissue course did not, just did not compare to the Perio Institute. It was just a lot of information, and I learned a lot from that course. So I thank you,
Yeah.
and just sort of got me, gave me more confidence. Because right at that time, well, I still am. I'm I'm not a confident clinician. I need to know. I need to have some sort of control. When things go wrong, I wasn't able to troubleshoot like the way you've taught me and Dr. Jin taught me how to troubleshoot cases when you're doing the cases. Um, Back then, those residence courses, there's just like a recipe: do this, do that,
Yes.
implant will go in. Well, honestly, most of them did not go in.
Mm. Mm.
So it's like, why? And
Mm.
imagine trying to treat a patient and you trying to seat this implant in,
Uh,
and it just wouldn't go in. And again, you taught me the fundamentals, what to look
mm.
out for, and I've gained more confidence. And then through that, I just gained more experience, and now I feel
Mm.
comfortable placing implants, thanks to you guys.
It's quite interesting because back then, me and Bernard, we were like two-man show. We did
Right.
everything. We taught all the courses, all the modules. Uh, we did our own posters, own marketing, own driving, own picking up pig jaws. We drove from Kamloops, Kelowna, all over.
And
It's
the
like
food, Mark, you probably did your own cooking as well, right?
yeah, that we like me and Bernard were looking at the cheap hotel, you know, share bedroom. Like that
Oh
that was it.
no.
It's like a traveling show. A traveling show. Basically, we're losing business, right? Yeah, we um that's why like I can never thank Bernard enough. And back then, I mean still now is too, but Bernard's strength and his passion has always been soft tissue, right? And so we went course together, and he was teaching soft tissue. It's been that's a long time ago. Ever since Jeff Lee came on board 6 years ago, we kind of let him do all the soft tissue teaching and things like that. Yeah. Because when I asked Neki when was the first time that he got to meet us, he said it was a Calgary PRF course. So all of my existing faculty have their first meeting through something, right? Yeah. But the funny thing about you, Michael, is I've known you for so long. I kind of forgot when I first met you, right? So this is kind of nice to hear from you how our first encounter was, right? Yeah. No,
But
that's wonderful.
Mark, I took all your courses. Uh, you, I don't know how you knew, but you noticed that I wasn't still confident enough, though.
Yeah. Yeah.
After I
Yeah.
took all your courses, and
Yeah.
you actually approached me to join the live surgery study club,
That's
and
right.
and
That's
and
right.
that's what that pushed me over the edge
Yeah.
there. It just gave me that that confidence. That
Because I come across time to time where the doctor knows so much but not confident to do the execution,
right,
right? But I also come across doctors, they do a lot of execution that they should not be doing, right? Yeah. They should take more courses. Like seriously, yeah, they're gonna hurt somebody. You know what I'm saying? Yeah, yeah. But you're the opposite. Yeah, you and doctor like there's another doctor just like you named Jason Adinata. Yeah, incredible clinician, but have what I call a little bit of a confidence issue, right? Now those I step over the line and I push, a little kick in the butt, say, you know what, Michael Wong, take this, get your confidence game up, right? And I think That's what I did to you, and you
Mhm.
listen, and the rest of it is really the history, right? Yeah.
Yes,
And I
yes.
start to see you really, your real strength start to come out, and then you start to enjoy sharing your knowledge, and you're such an integral part of our module 2, right? With
That's
Bernard,
right.
is it? Yeah,
That's right.
module 2. Yeah, which is a
Yeah, yeah,
principle of implant surgery, right? Yeah.
yeah.
So you're such an important part of it, right?
But
Before we move, yeah.
I wish I just had one more year of LSS. I really do.
You know what you'll
No,
do? You know why I kicked you out? I said, if I
I,
let you do one more year, you're gonna say,
yes.
"Can I do one more year again?"
Oh yeah,
Right?
for
It's
sure.
always the case. It's always the case. So no. You got kicked out at the right time, so that you come into our faculty, right? So it was the right time. A lot of the doctors for interested tonight, they're tuning in because of the topic, right? Yeah, hybrid guy. Give us a little bit of a what do you call that appetizer before we go into the main 15-minute presentation, right? Because you have a lot of topic that you could have covered. So, but when I got it with this topic, I was like, oh, why? Because you have so much other topics that is in your armamentarium, right? What made you feel that this is a topic that you have a passion for and that you believe that this is important?
You know, with the hybrid system, it's a double-edged sword for me. If you look at one respect, getting that initial osteotomy is the toughest for
Yeah.
for me. The precision and angulation. But at the same time, is I wish the let's say the novice clinicians that they don't rely on the static 3D guide from beginning to end. They should develop that free-handed placement. So in a way, that's why the hybrid is a good approach. It lets you establish that initial position and angulation of your osteotomy, but at the same time, it lets you develop your freehand, how the bone feels through the drill.
Hmm.
So I don't want the novice clinician, to use that as the one and only, um,
Hmm.
um, like the static guide. The static guide.
Hmm.
I really hope the novice clinician will develop their freehand skills as well.
At
So
some
that's why
point,
it's
like
important to
yeah,
me.
yeah, yeah.
Yeah.
That's right. It was like the opposite now. Like when we were training doctors, me and Bernard, we're teaching with the free hand, right? Because back then the guided surgery was so financially, prohibitive. It was so
Right.
expensive, so expensive. But now I see the opposite trend. A lot of doctors who are taking other courses, the manufacturing and they want them to rely on their guide system, and that's like they become a one-trick pony. And then when they have to do a free-handed situation, they really don't know what to do. Okay. Anyways, I'm,
Exactly.
I'm really looking forward to your 15-minute presentation because I always learn something from you. Even the stuff that I've listened to many, many times, I always find that there's always a pearl or two, well, when you are presenting, in front of the audience. So no further ado, Michael, I'm going to give you some time to go out and change and to apply some scrub and so that you can do your part of the presentation. It's like a magic, okay? Ladies and gentlemen, no further ado, today's topic, hybrid approach to implant placement. Dr. Michael Wong. Enjoy.
Hello, I'm Dr. Michael Wong, and today I would like to discuss with you the implant placement protocols that I use on a daily basis and why I prefer the hybrid implant placement protocol. So since the introduction of implantology in the early 1980s, the placement of dental implants were mainly surgically driven, and the outcome was mainly evaluated whether the implant was integrated or not. And it soon became clear that to restore these dental implants that meet the parameters that I listed here, the dental implant must be prosthetically placed, must be placed in a prosthetically driven position. Long-term implant therapy success is dependent on 3 factors. The implant must be placed in a prosthetically driven position, and it must be surrounded by sufficient amount of bone and in the presence of healthy soft tissue. If you're missing any one of these components, it can result in implant failure. So it has been pointed out by Buser in 2004 that a correct 3-dimensional implant position is a pivotal factor in an optimal aesthetic outcome. And Canolo in 2016 showed that nearly half of the peri-implantitis cases were triggered by implant malpositioning. To place an implant into this upper left premolar site, a digital wax-up or the conventional wax-up must be done, as this will help us visualize the prosthetic position of our final restoration. And with this in mind, the virtual implant is placed in a prosthetically driven position. And as our job as the clinician, we must somehow transfer this position into the patient's mouth. There are a couple ways of doing this. One way is using the free-handed protocol with the surgical guide or without the surgical stent. So that's the free-handed protocol with or without the surgical stent. And the other option is the computer-assisted protocol that uses the static surgical guide or the dynamic navigational guide. So today we'll be focusing on the free-handed protocol using the surgical Essex stent and the computer-assisted protocol using the static surgical guide. So the surgical Essex stent allows the clinician to check the prosthetic position and angulation of our osteotomy, an implant during surgery. And it is essentially a copy of the wax-up that was done in the planning stage. It has an occlusal opening, which represents the screw access opening of our final restoration. And the buccal window allows for accessibility and visibility of the surgical site. And with the CBCT images, the clinician is able to place this dental implant in the optimal prosthetically driven position. So, the free-handed implant placement protocol uses a surgical stent and CBCT planning as references during the implant surgery. And the actual implant position and angulation is determined intraoperatively after raising the flap and the bone exposed. So the accuracy depends on the surgeon's experience and skill. So with the advancement of digital technology in modern-day dentistry, the static computer-assisted implant placement protocol was developed. It uses a 3D planning software program like R2Gate, where we can virtually place that implant in the prosthetically driven position. As shown here, the digital wax-up is in green, and the implant is placed virtually. And this program allows us to modify and adjust the position and angulation of our implant in the mesiodistal plane and as well as the buccolingual plane. And with the magic of 3D printing, the surgical guide is fabricated. And along with the guided drills, this surgical guide will guide the drills and implants to the pre-planned position angulation, and depth. So with the surgical guide in place, the clinician introduces the guided osteotomy drills of increasing length and width, widening and deepening the osteotomy. And after using the final drill, the implant is placed with the same surgical guide. So the static computer-assisted implant placement protocol is also known as the fully guided because it allows the clinician to use the guided osteotomy drills from the initial drill to the final drill. And also, it allows you to place the implant with the same surgical guide. As you can see from the video, you can see how simple and straightforward the whole process is. But on the other hand, the free-handed protocol, the clinician is constantly checking and rechecking that axial position and angulation of the osteotomy drills, a process that can be quite tedious and time-consuming, especially for the novice clinician. And the hybrid placement protocol was developed to simplify this process of establishing the initial position and angulation of our osteotomy. So the hybrid placement protocol uses the surgical guide and the pilot guided drill. And this establishes the initial osteotomy position and angulation. And once this is confirmed, the final shaping and implant placement is done free-handed. And this protocol is also known as pilot guided for obvious reasons. So some of you may be wondering right now, why stop at the initial pilot drill? Why not continue with the fully guided, especially for the novice clinician? Well, you're absolutely correct. Studies have shown that without guides, the experienced clinicians were significantly more accurate than the novice clinicians. And with surgical guides, the differences in accuracy were eliminated for both single and multiple adjacent implant surgeries. Also, isn't fully guided more accurate than the free-handed or hybrid protocol? Won't you be introducing more positional inaccuracies, finishing your implant surgery free-handed? Again, yes, you're absolutely right. Let's look at this more closely. Well, here's the planned position of our implant. And the actual implant that was placed is shown here. So the implant can deviate in a 3D manner. And this can happen in the mesial-distal and buccolingual planes. So here, in the coronal aspect, the platform of our implant has shifted to the right to a lesser degree than the apical deviation that has occurred. Also, the implant can have an angular deviation with respect to the center of the implant. And this again can happen in the mesial, distal, buccolingual planes. So in a systematic review that was done by Tatan, they concluded that the fully guided protocol provided tangible clinical advantages as long as the clinical situation permits the stabilization of the surgical guide and an unhindered drilling sequence. So with the surgical guide in place, and if you notice, there's rocking in that surgical guide. The surgical guide is of no use to us as it will introduce positional inaccuracies in your final implant placement. And with the thickness of the surgical guide and the longer osteotomy drills, the guided osteotomy drills, quite often the drilling sequence would be hindered by the opposing dentition. And this is common in patients with limited opening. What they also notice is that the fully guided protocol has lower bodily and angular deviations compared to the free-handed protocol. So keep in mind, the free-handed, though it's more accurate than the free-handed, it still has a little deviations from the planned position. So my next question is, how does the fully guided protocol compare to the hybrid pilot guided protocol? Well, in this randomized controlled study, where they studied all three protocols, they once again found that the fully guided was the most accurate. And they also found that the apical deviation showed the largest disparity amongst the tested groups, with the free-handed group having the largest apical deviation. And you know, in the apical region, there could be vital anatomical structures that could be nearby, like the inferior alveolar nerve, the mental foramen, and in the upper, the maxillary sinus. And in narrow edentulous space, any slight deviation in the apical region of your implant can damage the adjacent tooth roots. What they also noticed is that 19.2% of the implants placed in the free-handed group had to be cement retained. So what does this mean? Well, in our planning process, we always aim for a screw retained restoration. And in this study, 19.2% of the implants that were placed in the free-handed group turned the screw retained restoration into a cement retained restoration. Interesting. And the pilot guided, the hybrid protocol, it reduced this percentage down to 4.2%. So what can we take away from this? Well, it can tell us that the hybrid pilot guided protocol definitely has a higher accuracy compared to the free-handed protocol. But the clinician must be aware of potential deviation with the conventional osteotomy drills from the initial pilot osteotomy. So great. The fully guided approach is most accurate. Same question, why hybrid? If we have the fully guided protocol, which can give us the most accurate placement. Well, here's your answer. In this randomized controlled clinical trial done by Smith-Karn, he found that the fully guided protocol did give us the higher accuracy in implant position compared to the free-handed protocol. But they also noticed that it came with a lower extent of primary stability. And he cautioned us by saying, caution is required in terms of case selection and planning because primary stability might be lower in the fully guided protocol. And how they measured this primary stability is through RFA and insertion torque measurements. So we know that primary stability is the mechanical stabilization of the implant, which helps us achieve osseointegration. Any micromovements greater than 50 to 150 micrometers will lead to soft tissue encapsulation of the implant and eventual implant failure. And one of the parameters affecting the primary stability is the bone density. So in the fully guided protocol, the rotational resistance that's present between the guide drill and the guide hole will affect the clinician's tactile perception of bone quality, which can result in oversizing your osteotomy in soft bone which can result in the need to bury your implant and committing the patient to a second stage surgery. And it could result in the inability to immediate load, especially in the case where you plan to immediate load. So the fully guided protocol will give us the most accurate implant positioning, but you, the clinician, must be aware that it's still prone to error. This could occur at any steps during the planning process, during the guide fabrication process, and even during the placement procedure. So it's recommended that you frequently evaluate the osteotomy at different stages of the fully guided protocol. Here's an example of a periapical that's taken after creating the initial osteotomy with the surgical guide and the pilot guided drill. So in the free-handed protocol, the main advantage for me is that it provides me a good tactile feel of bone quality, as this will allow me to determine if or how much undersizing of the osteotomy I need to do to attain that adequate primary stability. However, this does result in the least accurate implant position. And when multiple adjacent implants are involved, the free-handed protocol will be further challenged. This is because the clinician loses sense of direction with the lack of adjacent teeth. And this is where the hybrid protocol can shine, where it allows me to use the superior accuracy of the fully guided protocol and finish off with the implant placement with the superior tactile feel of the bone quality, so that I can create and establish adequate primary stability for successful treatment. So the hybrid protocol gives me that quote unquote, a good start is half the battle mentality. As a clinician myself, I spend the most time getting that initial position and angulation osteotomy correct. So as good as the fully guided protocol looks, it's quite tempting for most of us to use it as the one and only method for all our surgeries. However, I truly believe that the surgical guide and its protocol should be used as a tool. And the hybrid protocol is one example of how I use the surgical guide and its protocol as a tool in treating my cases. Thank you for your attention, and I hope you will give the hybrid protocol a try in your next case. In the meantime, take care. Goodbye.
Earpiece. Hold on. I lost my earpiece.
Wake up, Mark.
Okay. I did listen. I didn't fall asleep. I dropped my earpiece and had to drop it back in. Man, I tell you, like a magic. You switch your shirt just like that, and you switch back just like that. Okay, there you go. Okay. Now, we got some questions coming in. Yeah. So I think like you and I and Bernard and most of us old schoolers, we started with the freehand, and then we kind of not switched over, but we start to utilize guided surgery and start to mix together with our pre-existing knowledge of freehanding. But even though when we were freehanding, we never was a freehand. We had some sort of a reference, right? Like surgical stent, right? With the Essex with the hole cut out, like you had a slide for that. Yeah. I want to ask you, when you're doing a hybrid guide after that initial drill, for example, R2, and you get your initial drill, what is your next subsequent osteotomy drill sequence? Is there any particular drill sequence that you follow, right? Or is there some variation of it? Does it vary from posterior versus the anterior? Okay, yeah. What's your thought process?
Well, again, drill sequence all depends on whether your static guide has given you that ideal position angulation.
Mm,
So if you need to make changes, um, the Bytes has developed its own sort of drilling sequence to allow the clinician to change the position and angulation of the osteotomy. So that Bytes drilling sequence, well, I guess you have to take that CIR course, Module 2 too. um, and if the osteotomy position angulation is perfect, then I would just continue on with the just widening, and deepening that osteotomy because we're only going down actually with the hybrid guided protocol. We're only going down 7 millimeters.
mm, mm,
Um, by not committing to 10 millimeters or 12 millimeters, it's, it's an advantage because going down 7 millimeters is just more challenging to change that
uh-huh.
osteotomy's position and angulation. So, and we're only going 2 millimeter in diameter. I wish the guided drills came in at 1.5,
Mm,
honestly.
yeah.
Um, um, so that allows me to sort of change that position angulation if it's just slightly off.
Mm, mm,
Um, that's just my personal opinion because I like to go smaller and shallower for
yeah.
my initial osteotomy. And that allows me to position, get that
Mhm.
ideal positioning angulation of the osteotomy.
That's a good point. As much as I love MegaGen R2, I wish they combine all of their guided drill into one kit, right? Like they have a R2 have a R2 kit, which starts from 2 and widens out, and which is still better than a lot of other company. They start with a 2.5 or 2.8, which is too wide. So I think R2, their standard kit starting from 2.0 is not a bad thing, but they do have R2 narrow, which starts from 1.8, but when I measure the taper tip, it's actually 1.4. Yeah, yeah, so it's good. But I wish they combined it though. I gotta have
Right.
an R2 narrow, I gotta have an R2 regular kit, and I did a full arch anchor pin and all that. So I gotta have like all three of them, right? Yeah. So I do totally understand it. Yeah. Do you involve like a densa as a part of the drill sequence for when you're doing some of these cases?
Yes, I do.
Yeah.
For cases where there's the dense, I mean, you're not getting a lot of dense bone. I do use that denser drills. I also use it actually the densa and static guide combination where I
Mm,
establish that initial osteotomy with the static guide in immediate cases,
mm,
and then I use the densa because I find that densa has less chatter in
yeah.
immediate
Yeah.
cases.
Yeah.
You're not
Yeah. Right.
just
Yeah.
moving around. So but that's immediate cases. I use that
Yeah.
initial ostomy, the static drill, just to
Mhm.
get that initial spot, and then I finish it off with my denser drills. Yeah,
Yeah. But that's what I use a hybrid guide for all my full arch cases. Yeah. I don't do any of my full arch or fully guided
yeah,
because like I just don't trust them 100%. I
right,
don't. And a lot of my cases that I do, you're probably similar for you as well. A lot of the cases simply don't have enough bone to do fully guided. I need to split the bone. I need to graft the buccal wall. Majority of my full arch cases, the bone, alveolar bone is blown out. I have to rebuild. Yeah.
yeah, yeah.
So,
For
I don't
me,
always trust it. Yeah.
yeah, for me actually, I use more drills and then jump in free-handed for cases like the upper premolars or the canines. The
Mm-hmm.
canines I find that the toughest for me because the lateral has a different axial inclination.
Yes.
and the root inclination, and then you got the premolar beside it. It's like a
Which is
different
another different
angulation.
angulation.
That's right. So it's hard to sort of eyeball and freehand your way
Yeah.
through the surgery. So actually, I used a couple more guided drills to establish the length. After checking it though, after checking on the X-ray, I just go deeper, and then okay, this is the time to switch over to free hands
Yeah.
because I need to feel that bone
Yeah.
to know how much I should undersize or not at all.
See,
The
Michael, this is the thing, right?
yeah,
Like if it's a single, which is okay because it's a tooth-borne, so you can take it out to check in between, right?
right.
And you can take an X-ray. When I'm doing full large, it's tissue-borne. Pins are there. It's either I trust it or I don't. You
Right,
know,
right. Yeah.
that, that,
I don't know how
that
you
that's the
do it, Mark.
nerve-wracking part,
It's tough.
right?
Yeah. So you're
No, it's
putting your
easy. I
finger on the
pray. I
buckle.
pray the night
Okay.
before, and then we do
You
it.
close
Yeah,
your eyes
yeah,
and go by feel, right?
yeah. Because sometimes you kind of feel it if the bone is deflecting or something. You can't tell. I can feel it. Say, you know
Right,
what? Today that guide is not that accurate, and in those
right,
cases, I don't commit as deep as I would normally like, right? And
right,
so I have to
right,
modulate it. But like what you
right,
said is very important. Is at the end of the day, it's not the arrow, it's the archer, right? It's not the ingredient, but it's the chef, right? It's not the car, it's the driver.
right,
I mean, we say that, right? To us, there's no magic bullet, right? And guide is just another tool. Although a lot of the implant company want to make them believe that it is a solution, but it's not. Guide is not a solution. It is a tool. Yeah, and there are time and places for it. And I think where the hybrid guide sits really well is that it enforces the idea that guide forces us to plan, right? It forces us to treatment plan, look at the CT scan, and make us visualize what the ideal position should be. But at the same time, hybrid guide forces us to understand that at the end, it is a tactile haptic sensation of the bone that's going to speak to us to really know what the next drill sequence needs to be in order to achieve the stability, which is in my case and many of us is immediate loading is a big part of our implant practice, right? Yeah, so that's what it is, right? Um, Let me see right over here. There's some questions here. Yeah, I think Bernard. See, this is a thing. Bernard feels the uh, responsibility to ask questions on behalf of these millions of viewers, right? So he's got all this question here. Uh, what are your thoughts on trying to achieve stability even with poor quality bone? Okay, hybrid method, does bone quality, uh, the hybrid method, does the bone quality mess things up? Bone quality is always important. Yeah, I
Yeah,
think,
because you want to establish that primary stability. You need it
yeah,
for
yeah.
successful osseointegration there.
You didn't talk about correction of the angulation of the osteotomy. Let's say the guide wasn't seated properly or if the planning was not accurate.
That's
Well, I
that
mean,
that CIR course right there.
yeah, there you go. Okay, Bernard,
It's
come and
that
take
Vice
CR
drilling
course again,
sequence.
okay?
Yeah,
All right, stop
okay.
teaching. Start taking courses. All right. Have you ever used a guide only to find out that your osteotomy perforated out the labial or lingual once you switch over to the brain guided part? Okay. Once again, come and take the course, Bernard, okay? You
I
know
think
what is
everybody's
though?
getting ready for the Easter holiday, isn't it?
I think so. You know what I did notice though? When I used to send out my case to commercial lab, my guide was not always consistent. When we start to make our own guide in our own lab, it's far more became accurate. And I was talking to Kevin about it because what it happens is after doing many cases, they start to dial in, the printing parameters. the merging parameters, and and you start to understand your printing, your 3D printer and your scanner, so accuracy become more consistent, right? Yeah. So I don't think you send the case to anybody and they send you a guide and every guide fit the same. No, that's not the truth. There's a huge variation, huge variation. I think that's also important as well. Okay. Before I let you go, Michael, did you want to say anything to audience or to me?
No, I love you, Mark. I love you, me. No, I really appreciate what Vice has done for me in my implantology career. So I just I really thank you and Bernard from the bottom of my heart.
Well, thank you so much. David, what's our code for free HGD? Do we have one? Verification code BITES 20MW HBD. Okay, let me see. Bytes, 20-year anniversary. Michael Wong, happy birthday. Is it?
Wait, that's
hybrid,
you.
hybrid.
Oh yeah, happy birthday, Mark.
Okay.
Right?
Yeah, I told you happy birthday, bro. Yeah, my birthday was yesterday. Okay, thank you very much. Hey, Michael, thank you so much.
Yes.
Enjoy your tennis game. Okay. Get some sunburn. Come back alive. Or we'll have a beer together. Okay. Take care, my friend. Say hello to your wife.
Thank you.
All right.
Yeah. Bye-bye.
Wonderful. Thank you. All right, guys. That takes us to the end of episode 9. We have two more episodes remaining. Okay. I think one's from Dr. Kashko, and the other one will be Dr. none other than Bernard Jin. So he's saving the best for the last. Okay. We always appreciate all your support, and those of you who haven't had a chance to meet in person, I would really hope that sometime this year I get to meet you and shake your hand and person to person. Once again, those of you who are came to join us live, I really appreciate it. You guys take care, and those who are having a plan for a long weekend, have a safe trip, and we'll see you soon again. Take care. Bye-bye.